Bismillahirrahmanirrahim. Today we are going to start with the neurology sessions of our first aid series. And before starting the session, the book that I am using in these sessions is written and compiled by the great Dr. Moin Ahmed. And Dr. Moin Ahmed is a fresh graduate. He is a wonderful graduate and he has given me the kind permission to record these sessions from his book. I am very thankful to him for this. So now let's start with the embryology of the nervous system. The neural development. For the neural development, the first thing to be formed is called as a notochord, and it is coming from the mesoderm. It induces the overlying ectoderm to differentiate into neuroectoderm and form the neural plate. Notochord induces differentiation by the sonic hedgehog gene. The neural plate gives rise to the neural tube and the neural crest cells. Notochord becomes nucleus pulposus of the intervertebral disc in the adults. Now, if you could remember, so there the intervertebral disc of the adults has, if I draw an intervertebral disc like this, suppose this is the intervertebral disc, the central portion of the intervertebral disc is called as the nucleus pulposus, and the surrounding area of the intervertebral disc is called as annulus fibrosus. So this is nucleus pulposus. I'm sorry for this. This is nucleus pulposus, and the outer rim is called as the annular fibrosus. Annulus fibrosus. So whenever there is some sort of disc slip or disc herniation, the nucleus pulposus herniates outwards. Like there is sorry, it was a very massive disaster. Okay, so suppose that there is some sort of damage in the annulus fibrosus, then the nucleus fibrosus will come out or herniate out from the herniate outwards, and then it will impinge on some nerve at that particular level, and then symptomatology will be caused. So the whole concept of this diagram is to tell you that the nucleus pulposus is the central part of the intervertebral disc, and secondly, the nucleus pulposus is the remnant of the adult remnant of the notochords. Now here you can see that the alar plate dorsal, the alar plate is dorsal, that is for the sensory, and the basal plate is ventral, that is for the motor. Both have same orientation as spinal cord. Okay, so now let's see it over here. That very firstly, there is a structure from the mesoderm that is called the notochord that is formed. Now this notochord will induce the neural ectoderm above the notochord to form the neural plate. So if I could draw it over here, initially the thing that is happening is, suppose this is the hypoplast, and then this is the epiplast, and below that we have hypoplast, and this is an embryo like this, and this and this. Let me remove this. Yeah. So this is the upper layer is epiplast and the lower layer is hypoplast, and in the cut section of an embryo they look something like this. Below that is the yolk sac, and above that we have the amniotic cavity. So this epiplast and hypoplast later on degenerate, and they are converted into ectoderm. The middle one is the mesoderm, and below them we have the endoderm. There is a mesodermal derived organ, not organ per se, there is a mesodermal derived structure that is called as notochord that develops just over here. So now this is ectoderm, this one middle structure is a mesoderm, and below that we have the endoderm. So this mesodermal derived notochord induces the signal, releases the signal molecules upwards to the overlying ectoderm. The signaling molecules which are released by this notochord are called as sonic hedgehog, which are written like this, sonic hedgehog. So these sonic hedgehog molecules which are released by the notochord to the overlying ectoderm causes the differentiation of the overlying ectoderm into neuroectoderm. Now this neuroectoderm will look something like this. This neuroectoderm, this is now destined to become nervous system. So this is how the nervous system is derived from the ectoderm. Now this neuroectoderm will undergo different phases of differentiation. Let me draw them now over here. So firstly, the notochord has caused the formation of neural plate. Now this neural plate, the ectoderm, if you can see it over here, I'm sorry. So the ectoderm which is overlying this structure, now that has become neuroectoderm. The ectodermal cells start proliferating towards this central part, which is now neuroectoderm. When the cells are moving towards this direction, the neural folds are formed, which look something like this. Okay, now let me remove this. When the cells are moving in this direction, I think I should use a different canvas. Just give me a second. Okay, so we were talking about the formation of the neural fold. Okay, so this is something that okay, so when initially we have this ectoderm, and then we have mesoderm, and then endoderm, and all of them look like this, and this is the underlying yolk sac, and here we have now, this was the notochord, and notochord has caused the overlying and ectoderm to become neuroectoderm. Like this is the neuroectoderm. Okay. Now if you could see in this neuroectoderm, the cells, as I have previously said, that they start proliferating towards the central neuroectoderm, and they are moving like this. The cells are moving in this direction and this direction and this direction, this direction. So when the cells are moving like this, they cause uh, this neuroectoderm to lift from its surface. Like they start forming folds like this thing and this thing. Now let me make a clear diagram so that the things could be clarified. So if I remove it from here, like this structure, so this structure looks something starts looking like this. Like this is the structure, and there are neural folds in the center which are indenting and like this. So these folds are formed over there, and when these folds are formed, neural folds, the cut section will look something like this. The cut section will appear like this, that this is the neural tube, neural folds which are formed in the overlying ectoderm, and below that we have the mesoderm, and below the mesoderm we have the same endodermal layer and stuff like that. So this is the okay. So this is the endodermal layer below that. So the only change that has occurred in this phase is that the neural folds have formed. Later on, these neural folds will fuse with each other. These neural folds will fuse with each other, and they will start forming the neural tube. Now when a tube is formed, as you know that if I am saying that a structure is a tube, so it has two openings. There is an anterior neuropore and then also a posterior neuropore. This is an a side view of the neural tube that has been formed. This neural tube has definitely underlying notochord and all the layers which were previously formed. So this notochord is below the neural tube. Now this neural tube has two pores. This one is the anterior neuropore and this one is the posterior neuropore. So you must remember these things. These are the basic embryology of the nervous system. Now let's continue with our session. So we were talking about the development of the neural folds. As you can see that there are neural folds are formed, and after neural folds we have the formation of neural tube, and neural crest cells are also formed. If I could take you back, so when the neural tube is forming, there are some cells which let's draw it here over here. So when the neural tube is formed, like suppose now this is the ectoderm, below that we have this endoderm, mesoderm, and below that we have the endoderm. So there is the formation of the neural tube. Like this is the neural tube. Below that we have the small notochord, and some cells from the ectoderm which were not a part of the neural tube per se, but they were coming towards the neuroectoderm to aid in the formation of the nervous system. They hang alongside of the neural tube, and these hanging cells are called as the neural crest cells. So the neural crest cells are also shown in this picture. The neural crest cells, and the timeline is very important. The neural plate is formed on the day 18. On the 18th day we have the neural plate, and on the day 21 we have the formation of neural tube. Okay. So now here you can see that alar plate and the basal plate. If you have ever seen a cut section of a spinal cord, cut sections of spinal cord are very high yield. So you must always remember the cut sections. So if I draw a spinal cord over here with the red color. Okay, so if I draw spinal cord like this, and spinal cord has a central butterfly like this and this and this, so the dorsal plate, which is also called as the alar plate. So these dorsal plates, or you may say alar plate, these are sensory in nature, because you know that all the sensations of the body come to the dorsal root ganglion and then into the dorsal horns of the spinal cord. So dorsal or alar horns throughout the nervous system, mostly in the spinal cord and also even in the brainstem, and when you go into the brain, throughout the nervous system, the dorsal plates are sensory in nature, and the basal plates, which are ventral or anterior structures, they are motor in nature, or they contain motor neurons. And you know that the lower motor neurons come out from this, and this will do a detailed discussion about upper and lower motor neurons when we do respective sessions. But for right now, I just wanted to tell you that there are these structures. So now here you can see the regional specification of developing brain. Telencephalon is the first part, the diencephalon is the second part, and the rest are arranged alphabetically: mesencephalon, metencephalon, and myelencephalon. So here you can see that initially the neural tube that was formed, as we have drawn previously, the neural tube has three dilations, or three cavitations. These three cavitations are forebrain, that is called prosencephalon, then we have mesencephalon, and then we have rhombencephalon. These are the initial three dilations or initial three protuberances that are evident in the neural tube in very early stages of fetal development. Then later on, the forebrain of the prosencephalon is divided into telencephalon and diencephalon. The midbrain never divides, it remains midbrain or mesencephalon, so it remains as such. And the hindbrain or the rhombencephalon is subdivided into metencephalon and myelencephalon. Now to remember this, Dr. Najeeb used to give us some beautiful mnemonics. So for the diencephalon, he said that there is a Lady Diana. If you remember, Lady Diana was a queen of, she was a princess of Wales. So Lady Diana is standing over here, and there are telescopes which are always chasing Lady Diana, and they were also responsible for her death. But so Lady Diana is the symbolic of diencephalon, and these telescoping eyes, they are symbol of telencephalon. So the prosencephalon gets divided into telencephalon and the diencephalon. Diencephalon is the lower structures, and the cerebral hemispheres which are flaring outwards, these are telencephalon. Now we'll see these subdivisions later on, and then we have the mesencephalon, metencephalon, myelencephalon. Let's see the distributions. The telencephalon, which are these cerebral hemispheres, the telencephalon, which are these hemispheres, they are going to form cerebral hemispheres, and the cavity which is present inside them. Okay, let's talk about the cavities later on. Just give me a second. The telencephalon will give cerebral hemisphere. The diencephalon will give thalamus and hypothalamus. The mesencephalon will give midbrain. The metencephalon, which is a subdivision of the rhombencephalon. So metencephalon will give rise to pons and cerebellum, and the lowermost structure before spinal cord, medulla, is coming from the myelencephalon. Now what is the concept about cavities? Cavity is basically the brain is a hollow organ from inside. Like brain has a brain parenchyma, a substance, and then there are ventricular cavitations which are present inside the brain. So you can imagine that suppose this is our beautiful brain, like this, this something like this. So this is our brain. The brain is surrounded from all sides by meninges. Meninges are protective covering, so brain is like this. Like there are meninges, and there is cerebrospinal fluid that is present in the subarachnoid space to cushion the brain. So there is a water layer outside the brain to cushion it from external stresses, and then the brain has internal ventricular system which is giving an internal cushioning to the brain. So there is CSF that is present in the subarachnoid space outside, and there is ventricular fluid. It is basically cerebrospinal fluid that is present in the ventricles, that is cushioning the brain from the inside. So the brain has cavitations throughout. The cavitations have different names in different regions of the brain, but the brain is surrounded on outside by subarachnoid space and on inside by the ventricular system and cavitations. So I hope I could clarify the concept. Now let's move on to our discussion about the ventricular cavities. So the ventricular cavities, as I told you before, that each area of the brain has separate ventricular cavity. For the cerebral hemisphere, the cavity is the lateral ventricle. For the diencephalon, the thalamus and hypothalamus, the cavity is the third ventricle. Then cerebral aqueduct is the cavity of the midbrain. The pons and medulla have upper part of the fourth ventricle, and the lower part of the fourth ventricle is present in the medulla. We'll see all these ventricular system in detail later on. Then we have central and peripheral nervous system origins. Neuroepithelia in the neural tube form the central nervous system neurons. So basically the central nervous system, so you can a takeaway point for you is that central nervous system is coming from the neural tube directly, like the neural tube that we had formed above the notochord. This neural tube is going to give rise to all the structures which are present in the cerebral nervous system, almost all the structures, right? So central nervous system, which contains the brain and spinal cord, that is coming from the neural tube, while the peripheral nervous system is coming from the neural crest cells. Those cells which were hanging to the sides of the neural tube, which did not become a part of the neural tube, they are going to give rise to the peripheral nervous system. Or you may say that the cells which are peripheral to the neural tube are going to give rise to the peripheral nervous system. So let me remove this. So now the central nervous system neuron, neuroepithelia and the neural tube form the central nervous system neurons. Ependymal cells, inner lining of the ventricle, make the CSF. Oligodendrocytes and astrocytes. So central nervous system neurons and the glial cells, including the ependymal cell, oligodendrocyte and astrocyte, these are coming from the neural tube. From the neural crest cell, we have the peripheral nervous system and their myelinating cells, which are Schwann cells. The ganglion, collection of the neuronal cell bodies outside the central nervous system, are also coming from the neural crest cells. Mesoderm will give rise to microglia. Now microglia are like macrophages, and they are present in the central nervous system. They clear the debris whenever there is some kind of injury or stroke or bleeding or whatsoever. So they are, although they are present in the central nervous system, but they are coming from the mesoderm. So remember this point. Then we have Uworld notes. Anterior pituitary from the oral ectoderm, Rathke's pouch, and that is coming from the surface ectoderm, while the posterior pituitary neurohypophysis comes from the neuroectoderm. So if I draw a pituitary over here, I suppose this is the hypothalamus, and then we have the infundibulum stalk, and then this is the pituitary, and the pituitary has an anterior lobe and a posterior lobe. The anterior lobe is an outpouching of the oral ectoderm. Like suppose, let me remove it over here. Like suppose this is a person, and then this is the nose, and this is the mouth, and this is the pharynx. So basically, this anterior pituitary was initially an outpouching of the oral ectoderm, and then it became continuous, and then it fused with the posterior lobe of the pituitary and became, neuroectoderm. No, it became anterior lobe of the pituitary. So basically, it is coming from the outpouching of the oral ectoderm. It is called as the Rathke's pouch. So anterior pituitary is coming from the surface ectoderm, while the posterior pituitary is coming from the neuroectoderm. You must be able to see remember this difference. It is important. So let me remove this now. Then neurofibromatosis type 1 arises from the Schwann cells, that is the neural crest origin cells. The neurofibromatosis type 1 is coming from the Schwann cells, and they are neural crest in origin. Okay, so they are neural crest cell, they are coming from the neural crest cell as per the origin is concerned. Then let's talk about the neural tube defects. The neural plate deepens in the center to create the neural groove that is bound on both sides by the neural folds. The folds fuse to create a neural tube which is connected to the amniotic cavity by opening at the ends called as the anterior and posterior neuropods, as we previously have discussed. These openings close during the 4th week of the fetal life. Failure of the neuropods to close lead to the formation of neural tube defects entities. Presentation: persistent connection between the amniotic cavity and the spinal canal. Failure of the caudal neuropod to close will lead to spina bifida. Spina bifida in most of the situations is viable. It is compatible with life, and the fetus is viable. While the failure of the rostral or cranial neuropod to close will lead to anencephaly, and there will be a complete absence of the brain, and such fetuses are not viable with life. They are either aborted spontaneously, or they may be delivered but they will be stillborn. And increase alpha fetoprotein. Now there are some markers which we use. Increase in alpha fetoprotein in the amniotic fluid and maternal serum except spina bifida occulta, in which we have the normal alpha fetoprotein. Alpha fetoprotein also increases any body wall defect. For example, we see an increase in the alpha fetoprotein in the Down syndrome. If I am not misleading myself, alpha fetoprotein. Let me check that. Alpha fetoprotein in the Down syndrome. In Down syndrome, alpha fetoprotein in Down syndrome is yes, called multiple markers. These tests. Okay, so what are the levels? Alpha fetoprotein level, Down syndrome, it is less than no alpha fetoprotein higher or another. Yes, okay, so alpha fetoprotein in Down syndrome is likely to be low. So this is a difference. I'm sorry, I was wrong. I'm sorry. Alpha fetoprotein in Down syndrome will be low, while in the case of body wall defects or neural tube defects, that is going to be high. So there is a mnemonic in general pathology. We'll see that later on. But there is a mnemonic that we call he man is an alpha male. So he man is an alpha male. So there is a mnemonic that tells us that there are different kind of things that give rise to an increase in the alpha fetoprotein, and Down syndrome is not one of them. And in Down syndrome, the level of alpha fetoprotein is down. Remember it like that. So in any kind of body wall defect, we will have an increase in the alpha fetoprotein. Increased acetylcholine esterase in amniotic fluid is very helpful confirmatory test, because the acetylcholine is a neurotransmitter. Acetylcholine esterase is usually present in the synapses, right? And if there is some kind of defect in the nervous system, that acetylcholine esterase starts spilling out into the amniotic fluid. And if we find high level of acetylcholine esterase in the amniotic fluid, that is also a diagnostic point for the neural tube defects. It is associated with the maternal diabetes as well as low folic acid intake. This is a very important thing and a buzzword. If there is, if the test question makers, they want to take you towards neural tube defect, they will somehow mention folic acid defect in the question stem. So low folic acid intake before conception, during the pregnancy and during the pregnancy is also a risk factor. So whenever a mother is planning pregnancy, she must start taking folic acid even before, like 1 month before conception or something. No. If she is planning a baby, even before preparing for that, even before having a sexual contact with a partner, she must start taking folic acid 1 month prior to that. Folic acid antagonist I'm sorry, folic acid pardon me for that. So folic acid antagonist, there are some anti-epileptic drugs like trimethoprim during pregnancy are risk factor for the neural tube defects. Maternal serum alpha fetoprotein screening. If there is high maternal serum alpha fetoprotein, so that is seen in the open neural tube defects, for example the anencephaly or open spina bifida, ventral wall defects, for example omphalocele and gastroschisis, and then we have multiple gestations. All of these things can lead to an increased level of maternal serum alpha fetoproteins, and decreased maternal serum alpha fetoprotein is seen in the aneuploidies like trisomy 18 or maybe trisomy 21. Then let's move to the next point, that is about this thing. Yes, these are different types of spina bifida. So this is a normal thing. In this normal thing, you can see that the vertebral arches are completely closed, and the spinal cord is surrounded by the dura mater and the leptomeninges, which are arachnoid matter and the pia mater. Then we have the subcutaneous tissue, this thing, and over that we have skin, and everything is just right in its place. In the second thing that we call spina bifida, that we call spina bifida occulta, that is the most common variant. In this, the vertebral arches have a defect, like there is a defect in the vertebral arches, and there is no other problem. Everything is just in its place. The spinal cord surrounded by dura mater and leptomeninges is present inside the spinal canal, right? It's not called spinal canal per se, but it is present, in its usual position. And then we have the skin overlying the vertebrae, and the only thing that tells us that there may be a spina bifida occulta is that there will be a tuft of hair that will be present on the skin, and that is not a mandatory thing to be present. They may or may not be present, and skin dimple also may or may not be present. Then meningocele is the condition, meningocele over here. The meningocele is the condition in which from the defect in the vertebral arch, the meninges like the dura mater and the leptomeninges, they herniate outwards and they remain below or under the skin. In the case of myelomeningocele, and that is not compulsory to stay below the skin, there may be a skin defect or thinning as well. And then we have a myelomeningocele in this particular case, spinal cord as a whole, or maybe because the spina bifida spina bifida is happening in the lower segment of the spinal cord. So if it is happening below the level of L2, 3 or maybe L4, so there is the spinal cord, as you know, that terminates at the level of L2, and for the children it is L3. So if the spinal cord has terminated at the level of L3 and there is a defect in the vertebral arches or the skin below that, spina bifida is happening below that, so the cauda equina will be herniating outwards, right? What is cauda equina? Cauda equina is a tuft of nerves which are hanging down the termination point of the spinal cord. We'll see that later on as well, but for right now, just for conceptual purposes, the herniation of the brain tissue, the herniation of neuronal tissue, and along with that, if we have meninges, so that is called as myelomeningocele. Moving forward, spina bifida occulta. Failure of caudal neuropore to close, but there is no herniation. Spinal tube fails to induce the bone to form vertebral arch. So, in an embryo, I'm just making an analogy. If we have formation of one structure and then there is another structure, then there is another structure, all these three structures are communicating very excessively with each other and they are inducing each other's development. If we remove any of them, like if we remove this structure from the middle, maybe there is no development of this or this structure. So this is very important for the induction of the different structure to take place during the embryogenesis. So spinal tube fails to induce the bone formation and to form the vertebral arch. Missing spinous process will lead to a bony defect, usually seen at the lower vertebral levels, and the dura will be intact, associated with a tuft of hair or skin dimple at the level of bony defect, and there will be normal acetylcholinesterase and alpha fetoprotein, and the child will also be asymptomatic for the rest of his or her life. There will be no problem. Then spina bifida cystica, there will be increased alpha fetoprotein, there is body wall defect with normal acetylcholinesterase, neural tissue is not exposed outside. So spina bifida cystica is a condition in which we have increased alpha fetoprotein, but the acetylcholinesterase level is normal because the neural tissue is not exposed outside, like it is covered by the skin. So it has subtypes which is called as the meningocele and myelomeningocele. So remember, if the skin is intact and there is some problem underlying that there is herniation of the meninges or maybe also the spinal cord, but the skin is intact, that is called as spina bifida cystica. right? And the skin is also broken, or maybe there's direct communication of the neuronal tissue with the outside environment, that is called as myeloschisis, right? We'll see that later on. So the meninges but not the neuronal tissue herniate through the bony wall defect, as we have seen in this picture. Like the meninges are herniating outward, this one, like this one. Now let's move to the meningomyelocele. Meninges and neural tissue, for example the chorda equina, herniate through the body defect, almost always has the Chiari 2 malformation. Chiari 2 malformation is a scene, it is a problem. Like suppose this is a skull and this is a foramen magnum. From the foramen magnum, if the cerebellar vermis and the cerebellar tonsils, if these two structures are herniating downwards, that is called as Chiari 2 malformation, and the Chiari 2 malformation is most of the time associated with the myelomeningocele. Like both the meninges as well as the spinal cord or the chorda equina, they are herniating outwards out from the vertebral arch. Hydrocephalus, major cause of mortality, obstruction of the fourth ventricle outflow due to the compression by the cerebellar herniation in the Chiari 2 malformation. Although myelomeningocele is present in the Chiari 2 malformation, the main cause of death is the hydrocephalus. Like suppose if we see it over here, that below that, like this is the foramen magnum, and below the foramen magnum we have the spinal cord and stuff like that. If the cerebellar vermis and tonsils are herniating outwards, they will obstruct the outflow tract of the ventricles. If the ventricles outflow tract is obstructed, the ventricular system communicates with the subarachnoid space freely, and they use foramen of Magendie and foramen Lashka of the fourth ventricle for that purpose. If those foramina are blocked by the herniating structures, the fluid will start accumulating inside the ventricular system, and the fluid will accumulate, and that will cause hydrocephalus. And the cause of death in such cases is mostly hydrocephalus. So now let's move forward to the myeloschisis, also known as rachis, exposed unfused neural tissue without skin or meningeal covering. So there are two things: there is no skin and no meningeal covering. There is totally exposed neuronal tissue to the outside environment. There will be increased alpha fetoprotein and increased acetylcholinesterase. So in all other cases, like in spina bifida occulta, we had normal acetylcholinesterase as well as alpha fetoprotein. In spina bifida cystica, alpha fetoprotein was increased, but the acetylcholinesterase level was normal. Only in the case of rachis or myeloschisis, we have elevation of both the alpha fetoprotein as well as acetylcholinesterase. Then let's talk about the anencephaly. Failure of the rostral anterior cranial neuropore to close. There will be no forebrain and open calvarium will be present. There will be a frog-like appearance of the fetus. Increased alpha fetoprotein and increased acetylcholinesterase will be present. It is associated with the maternal polyhydramnios. Fetal swallowing of the amniotic fluid is impaired. So you know that when the fetus is present in the mother, like suppose this is the womb of the mother and fetus is present inside like this and this. So fetus swallows the amniotic fluid and then urinates it and then swallows it back. So this cyclical movement of the amniotic fluid keeps the amniotic fluid level in check. If the fetus cannot digest or swallow the amniotic fluid, the amniotic sac will start becoming large. Why will it become large? Because there is excessive accumulation of the amniotic fluid inside that, and that will result in the polyhydramnios. And polyhydramnios can have a lot of pesky complications like Porter sequence and stuff like that. No, Porter sequence is with the oligohydramnios. I'm sorry. The polyhydramnios has other associated complications. We'll see them later on. So this is the picture of the frog-like face and everything like that, and there is no brain at all. So this is the picture of anencephaly, and these children are not viable with life. Holoprosencephaly, embryology, failure of the left and right hemisphere to separate. In normal human being, you know that this is the left hemisphere, and then we have an indentation, then we have the right hemisphere and stuff like that. If the right and left hemisphere are not separate and they are just fused together, there is only one hemisphere. This is called as the holoprosencephaly. Usually occurs during week 5 and 6. Etiology can be genetic as well as environmental. The genetic may be related to the mutation in the sonic hedgehog signaling pathway, because there are a lot of signaling molecules, and for a lot of different structures we have a lot of different kind of signaling molecules. But for the central nervous system, if we are supposed to remember one signaling molecule, remember this one, sonic hedgehog. Okay, right? So for the genetics, may be related to the sonic hedgehog signaling pathway. Then it is seen in the trisomy 13, like in the Edward syndrome. No, that's not Edward, that's Tau syndrome. Trisomy 13 is Tau syndrome. The trisomy 18 is Edward syndrome. So it is Tau syndrome. Then environmental fetal alcohol syndrome. So if the mother has been taking alcohol excessively, or she was taking alcohol and she did not know that she was pregnant, because as you know that the development of the nervous system starts as early as in the 3rd week of pregnancy, and that completes by the 4th week. So when it is so it is that time in which most of the mothers usually do not know that they're pregnant. So if the mother is using alcohol in this particular time and she is binge drinking, so that can be a risk factor for the development of holoprosencephaly in the child, in the fetus. The clinical feature range from a phenotypic there is a range of phenotypic finding in the children. In mild cases, we have closely set eyes, that is called as hypotaylorism. There will be cleft lip and palate. In very severe cases, there will be single midline eye, that is called as cyclopia. There will be primitive nasal structure, that is called as proboscis, and mid-facial clefts will also be present. Like here you can see that hypotaylorism means that the eyes will be close to each other, so that can be present. So this the first one is a very mild kind of holoprosencephaly, in which we have the median cleft lip or cleft palate. Then we have a single nostril or nose and hypotaylorism. So you can see that the eyes have come closer in this picture. Then hypotaylorism and proboscis, non-functioning nasal structure. There is no, this is proboscis, like the child does not have a nose, and the non-functioning nasal structure is present. And then there is central orbital fossa and proboscis, and you know there is only one eye, and then there is proboscis and stuff like that. So this is a very horrible complication. The Uworld point, it is an example of congenital malformation. It is very important. You must be able to differentiate between malformation and sequences and associations and stuff like that. So these things are very high yield points for the step exam. Then we have posterior fossa malformations, Chiari 1 malformation, ectopia, which is mean protrusion of the cerebellar tonsil. If only one structure is protruding outward, that is tonsil, it is called as Chiari 1 malformation, as you can see in this picture, that the Chiari 1 malformation, and this is mostly associated with Syringomyelia. We'll see that. So Chiari 1 malformation has the herniation or ectopia of one structure, that is called the cerebellar tonsils. Congenital, usually asymptomatic in childhood, manifest in the adulthood with the headaches and cerebellar symptoms. It is associated with spinal cavitation, for example, Syringomyelia. So there are two Chiari malformation which you have to remember for your step exam. So these Chiari malformation, the Chiari 1 malformation is associated with the Syringomyelia, and Chiari 2 malformation, as we previously have seen, is associated with the myelomeningocele. So now let's continue. Just give me a second. Yeah. So Chiari 1 malformation, then we have Chiari 2 malformation, herniation of low-lying cerebellar vermis and tonsil. That now there is herniation of two structures through the foramen magnum with aqueductal stenosis, and that aqueductal stenosis will result in hydrocephalus. As we have previously discussed, when there are two structures which are coming out of the foramen magnum, they will cause the stenosis of the cerebral aqueduct. And that cerebral aqueduct, which was supposed to drain the fluid from the lateral and third ventricle into the fourth ventricle, if that has been occupied, if that has been obstructed, there will be non-communicating hydrocephalus, and that will result in enlargement of the skull and stuff like that, and all the pesky complications which are associated with hydrocephalus. So Chiari 2 malformation is associated with hydrocephalus, as well as it is usually associated with the lumbosacral meningomyelocele, may present as paralysis, sensory loss at and below the level of lesion. There is a syndrome that we call the Dandy-Walker syndrome. It is the failure of foramen Lashka and Magendie to open, and there will be a dilated fourth ventricle. Agenesis of the cerebellar vermis lead to the cystic enlargement of the fourth ventricle that fills the enlarged posterior fossa. Now, there is a picture of that Dandy-Walker malformation, as you can see in this picture, that the fourth ventricle that was supposed to be present like this only, that is enlarged all the way over here. Like this is now. The fourth ventricle is like this. So the fourth ventricle, which was supposed to be a very small structure, now is enlarged. The cerebellar vermis that was supposed to contain the fourth ventricle, which was supposed to be present over here, now that is absent, and the fourth ventricle is enlarging and occupying most of the posterior fossa like this. And it is a different angle of the CT, and you can see this like this and over here. Now moving back over here. So agenesis of the cerebellar vermis lead to the cystic enlargement of the fourth ventricle that fills the enlarged posterior fossa. It is associated with a non-communicating hydrocephalus. It is due to atresia of the foramina of Lashka and Magendie. Now for the fourth ventricle, you must remember, if I draw two pictures of fourth ventricle, this is the fourth ventricle which looks something like this. This is the side view and this is the front view. The fourth ventricle looks something like this, and it is a diamond shaped foramen. So it looks something like this. So like this. There is a central spinal canal which is going into the spinal cord, and there is a central opening. So the foramen of Magendie is present in the center, and foramina of Lashka are present on the sides. I remember it like that, that foramina of Lashka are present laterally, while foramen of Magendie is present centrally. So these are the foramina. If there is agenesis or atresia of these foramina, so the fourth ventricle will not be able to drain the cerebrospinal fluid into the spinal canal, neither into the spinal canal nor into the cerebrospinal fluid surrounding the brain in the subarachnoid space. And if the fluid is not draining into these cavities, the fourth ventricle will start enlarging. On top of that, if we have the degeneration of the cerebellar vermis, that degeneration will result in enlargement of the fourth ventricle, and it will start occupying the majority of the portion of the posterior fossa. It results in the system of the elevated intracranial pressure, that is irritability and vomiting, and it is also associated with the spina bifida, right? So Dandy-Walker syndrome is also associated with some variants of spina bifida, but the high yield points which you should remember for the board exam is that Chiari 1 malformation is associated with the Chiari 1 malformation is associated with the Syringomyelia, and the Chiari 2 malformation is associated with the myelomeningocele and hydrocephalus. Now let's come to the point, the red arrow, agenesis of the cerebellar vermis. Here you can see in this picture that the red arrow which is present over here, this is showing the degeneration of cerebellar vermis somehow, and the blue arrow, it is cystic dilation of the fourth ventricle with the posterior fossa enlargement. Then Syringomyelia. Syringomyelia is a cystic cavity or syrinx within the central spinal canal, central canal of the spinal cord, syrinx tube, or as in syringe. Most common at C8 to T1 level, affecting the upper spinal cord. It is very important to remember this level because this will give us a cape-like distribution of the abnormalities of the problems. So cystic cavity within the central canal of the spinal cord. Then we have the most common C8 to T1 vertebrae are most common involved in fibers crossing in the anterior white commission, which is the spinothalamic tract, are typically affected first. So here you can see that Syringomyelia, the spinothalamic pathway, that is for the pain and temperature, that is traversing like this. Like these pathways are coming from the dorsal horn of the spinal cord. They decussate at the anterior commission and go to the contralateral side, and then they ascend upward. So basically they decussate inside the spinal cord, or they cross to, decussation means crossing to the opposite side. So they cross to the opposite side within the spinal cord at the level of this thing, that anterior commission, like this point. Now this is the very point, and now let me remove this. Now the central canal of the spinal cord is present over here. If I draw spinal cord over here, if I draw it like this, if the spinal cord is drawn like this, and it has a butterfly in the center with the dorsal and the ventral horn, the dorsal Eller for the sensory and the ventral or basal horn for the motor system. So the central canal is present something like this, right? And as we have just discussed that the spinal thalamic tract is coming from each side, and then it crosses in the anterior white commission and then ascends to the opposite side like this, and same is true for the contralateral side. If the central canal, this central canal, I have to zoom it in, I guess. Okay, if the central canal starts expanding, this central canal starts expanding, so it first of all it moves anteriorly, and when it moves anteriorly, it can occupy the spinal thalamic tract, it can damage them, and then there will be a loss of pain and temperature sensation at the level of damage. And as we have previously seen that the most common level of damage is the C8 to T1 vertebra. So there will be a cape-like distribution. Cape is, if you have seen Superman, so Superman has a cape, or the red cloth that is hanging on the back for no reason. So that cape-like distribution is seen. The cape-like distribution of loss of pain and temperature sensation is seen in the Syringomyelia, as they have written over here. Fiber crossing the anterior white commissure, spinal thalamic tract species damage result in a cape-like bilateral symmetrical loss of pain and temperature sensation in the upper extremities. Fine touch sensation is preserved as it runs in the posterior columns. We will see these sensations later on. Associated with a Chiari malformation. Okay, Chiari 1 malformation. Red arrow shows the low-lying cerebellar tonsil in the A. So is there any A? I guess there is an A. So here you can see that this is the cerebellum, and then the cerebellar tonsils are lying low. They are not supposed to be that low. And then later on we have this central canal, like this cavitation that is present, like this white cavitation that is present inside the spinal cord. Then we have it over here that tonsil and other congenital malformation acquired causes include the trauma or tumors. Syrinx expansion results in the involvement of other spinal tracts leading to muscle atrophy and weakness with a decreased muscle tone and impaired reflexes due to damage to lower motor neurons of the anterior horn cells, and Horner syndrome with ptosis. Horner syndrome with ptosis, droopy eyelids, meiosis, constricted pupils, and anhidrosis, decreased sweating due to the disruption of the lateral horn cells of the hypothalamic spinal tract. Lateral horn cells of the hypothalamospinal tract. Okay, then we have this thing over here, that is loss of pain and temperature sensation affected dermatomes are C5 to T4 as shown here. So most affected area is C8 to T1, right? But otherwise involved areas can include from C5 to T4 dermatomes. Then this is the explanation of that there is syrinx that is affecting multiple dermatomes, and afferent lateral spinothalamic tracts are most commonly affected because they are crossing the anterior wide commissure and stuff like that, and anterior wide commissure compressed with the syrinx. Okay, then here you can see, I guess this is a picture from the Uworld or maybe the first aid, but the discriminative touch that is taken by this dorsal column is intact, that is not affected. The fine touch, the touch that we do with a pinpoint needles and stuff like that, that is intact, but the pain and temperature along with the crude touch is lost. The crude touch is the touch done with a cotton wisp or something like that. Bilateral interruption of the pain and temperature sensation is happening because of syringomyelia. Okay, so here I would like to tell you about something. This is, we are talking about Syringomyelia, right? Syringomyelia is a expansion of the central canal of the spinal cord. If I say you Syringomyelia, that is a totally different disorder, and the Syringomyelia is also called as a mermaid baby, and it is a caudal agenesis syndrome in which when the mother is diabetic, so the lower limbs of the child may be fused together and the child will look something like a mermaid. We'll see that later on when we do the repro sessions, but that is Syringomyelia. So now let's come to the tongue development. Tongue is developing from the anterior 2/3. So tongue develops from the anterior 2/3 of the tongue comes from the first and second branchial arches. Okay, the sensation is coming via the CN53 and CN7. That also makes sense because CN5 or the trigeminal nerve is the nerve of first branchial arch, and facial nerve is the nerve of second branchial arch. If anterior 2/3 of the tongue is coming from first and second branchial arch, so the nerve supply is also coming from their respective branchial nerves like CN5 and trigeminal nerve. But the difference is the CN53 or the mandibular branch of the trigeminal nerve is going to take the sensations, the somatic sensation like the touch, pain, temperature, stuff like that. The CN7 is going to take the special sensation, that is the taste sensation. Posterior 1/3 from third and fourth branchial arches. So posterior 1/3 is coming from third and fourth branchial arches. The sensation is taken mainly by the glossopharyngeal nerve. That is also, glossopharyngeal nerve is the nerve of the third branchial arch. I think so. Yes, and posterior by vagus nerve. So 3, 7, 9, 10. Yeah, third and fourth pharyngeal nerves are like, for the third we have the 9th cranial nerve, and for the fourth we have the 10th cranial nerve and stuff like that. Motor innervation is via CN12, and CN12 gives an hypoglossal nerve, provides the motor innervation to the tongue, to the hyoglossus. The CN12 is the main motor nerve for the tongue that gives innervation to the hyoglossus muscle, which retracts and depresses the tongue. The genioglossus muscle, which protrudes the tongue. Genie protrudes, why so? Because if you have seen Aladdin or something like that, so there is a lamp, and when he rubs the lamp, so genie protrudes out from the lamp, and that stuff like that. So that is why the genioglossus protrudes the tongue, and styloglossus draws side of the tongue upward to create a trough for swallowing. The CN10 gives innervation to the palatoglossus, which elevates the posterior tongue during swallowing. Then here you can see the picture, tongue sensory innervation. The anterior 2/3 of the tongue is emitted. The anterior 2/3 of the tongue, the taste sensation are coming from the coda tympani nerve, and the trigeminal nerve gives the general sensation. The median sulcus is present over here, and here this is none of your concern. This is an ulcer. Actually, this is a picture from the first Uworld, and they were showing some ulcer and stuff like that. This is the terminal sulcus, and then we have the posterior 1/3 of the tongue glossopharyngeal nerve, and this is the vagal nerve area. The red area is supplied by the uh, trigeminal, the mandibular branch of the trigeminal nerve CN5-3 for the sensations, and the taste fibers are taken by the coda tympani nerve. Yes, and then we have posterior 1/3 of the tongue, that is the taste fibers are taken by the glossopharyngeal nerve, and very posteriorly we have vagal fibers which are taking the taste sensation. Uh, the sensation of taste, okay, sensation by that tongue. And if I am not wrong, the sensory fibers throughout the tongue, anteriorly, posteriorly, that is taken by the cranial nerve 5. No, no. It's not like that. I was right previously that the cranial nerve 7 takes taste sensation from anterior 2/3, and cranial nerve 5-3 takes general sensation from anterior 2/3. From the posterior 2/3, it is less confusing because the same nerve is taking the taste fiber as well as the general sensation. The CN11 is the CN9, the glossopharyngeal nerve from the posterior 1/3 of the tongue is taking the taste and general sensation fibers, and the vagus nerve from very posterior part of the tongue is taking the taste and general sensation fibers. So it is like that. So the mandibular nerve is confined to the anterior portion, anterior 2/3 only. Then we have the side vein, which you can see anterior 2/3, and then the terminal sulcus is over here in the posterior 1/3. Moving forward to the neurology, the taste sensation. The taste sensation is taken by the CN7, 9, 10 to the solitary nucleus. The pain is taken by the CN5-3, CN9 and CN10, and the motor fibers are coming from CN10 and CN12, mostly by CN12 and somewhat by CN10 to the palatoglossus as well. The genie sticks out his tongue. That is because the genie glossus protrudes the tongue outside. Then anatomy and physiology. So there is a general flow sheet diagram about that. The CNS cells are divided into two types of cells. Firstly, neurons, and then we have the non-neuron cells, which are called the glial cells. The macroglia, the glial cells are subdivided into macroglia as well as microglial cells. The microglial cells are a separate class of cells. These are basically macrophages, and these macrophages are coming from which layer? They are coming from mesoderm, right? As we have previously seen. So macrophages or microglia, and the macroglia cells contain astrocytes, the oligodendrocytes and the ependymal cell. We will see the functionality of each of these cells later on, but astrocytes are very important for the scar formation for gliosis, reactive gliosis. Oligodendrocytes are responsible for myelination of the neurons of the central nervous system, and the ependymal cells are very important for the formation of cerebrospinal fluid inside the ventricles from the choroid plexus. Now let's talk about the glial cells. Glial cells are support neurons. What is gliosis? Gliosis is the proliferation or hypertrophy of the glial cells, that is reaction to the CNS injury, and astrocytes undergo major changes. So whenever they are talking about gliosis, they are most of the time referring to the astrocyte proliferation. So suppose this is the brain like that, and this. So if there is injury to this particular point, in this particular area will start the astrocytes will start proliferating, and that proliferation is called as reactive gliosis. And this reactive gliosis is if we do the biopsy of this scar that is found, most of the cells will be of astrocyte origin. Then we have the second type of cell, which are called the second thing that we need to focus is glioma. Glioma is the neoplasm of the glial origin, for example astrocytoma, ependymoma and oligodendroglioma. They stand positive for GFAP, glial fibrillary acidic protein or something like that, for GFAP. So all the gliomas like glioblastoma multiforme is a glioma, it is an astrocytoma, so that stands positive for GFAP. Then so GFAP, although it is a tumor marker for astrocytomas, but in general the GFAP is present in all the glial cells, all the gliomas. Then neurons, signal transmitting cells of the nervous system. Neurons are the signal transmitting cells of the nervous system. They are permanent cells and they do not divide in the adulthood. It means that, as we'll see later on, that there are cell cycles. So if suppose there is a cell cycle and this is divided into G1 phase, and after the G1 phase we have this S phase, and after S phase we have that we have G2 phase, and then we have this M phase and stuff like that. So there is thing that called G0 phase. Some of the cells remain temporarily in the G0 phase, for example the hepatic cells, or maybe the hepatic cells. Some of the cells always remain in the G0 phase, for example the smooth muscle cells, not the smooth muscle cells, skeletal muscle cells, for example the skeletal muscle cells or the neuronal cells. So they are permanent cells, they never divide, they do not divide in the adulthood. Single relaying cells with they are signal relaying cell, the signal relaying cell with the dendrites which receive the input, and the cell bodies and axon which send the output. So if suppose this is the these are the dendrites, so signal coming from the neuron that is present over here, like suppose there is a neuron that is present over here, so the signal will come on the dendrites, it will travel on the axon, and then it will from the axonal terminus it will move to the next neuronal dendrites and stuff like that. So the cell bodies and dendrites can be seen on the nissil staining that stains the rough endoplasmic reticulum. Rough endoplasmic reticulum is not present in the axon. So if you have to differentiate between the cell body, the dendrites, or the axon, use a nissil stain. The nissil stain will stain the rough endoplasmic reticulum. If the area is being stained, it means that it is either cell body or dendrites, and if it is unstained, it is axon. We'll talk about Valerian degeneration in the next session. Until then, Allah Hafiz, fi amanillah, and take care.